allow me to introduce our speaker this evening. He is a graduate of the UP College of Medicine, class 1986, and proceeded for his residency training in obstetrics and gynecology at the University of the Philippines, Philippine General Hospital, where he became the chief resident during his last year of training. He had his fellowship training in infertility and reproductive medicine at the Free University of Brussels in Belgium under Professor Paul Devry. He had his master's in the biotechnology of human-assisted reproduction and embryology, Instituto de Valencia in Fertilidad, and the University of Valencia in Spain in 2015 to 2017. He is an associate professor, section of reproductive endocrinology and infertility, Department of OBGYN of the University of the Philippines College of Medicine and PGH, a vice service chief of the Department of OBGYN, and he is the head of the section of reproductive endocrinology and infertility of the St. Luke's Medical Center globally. He's also the head for the Center for Advanced Reproductive Medicine and Infertility of the St. Luke's Medical Center in Global City. He is the founding president of the Philippine Society for Fertility Preservation, past president of the Philippine Society of Reproductive Medicine, member and board of trustees of the Philippine Obstetrics and Gynecologic Society. He has numerous research publications, both local and international peer-reviewed journals under his cap, and he has several ongoing papers and research publications on IVF, infertility, male fertility, AMH, and ART. He is an editor, author, and contributor to published scientific handbooks and CPGs, and recipient of awards and recognitions, such as the Dean's Gold Medal Award, UP College of Medicine, and the Silver Star Award for Infertility. Ladies and gentlemen, please help me welcome our speaker tonight, Dr. Virgilio M. Novero, Jr.
Thank you. Thank you very much, Dr. Arthur Louis, for that very kind introduction. Thank you also to my contemporary in UP Los Baños, your chair, your division chief, Dr. Spike Ignacio. We call him Spike because then he likes to spike a lot during volleyball. And I still remember our plays in basketball and volleyball back when we were still more agile. Okay, so I'd like to start off by sharing my screen. Okay. So before I start, I'd like to congratulate the Division of Medical Oncology for their 40th anniversary, and I'm very honored to be included in their celebrations. So the topic that was requested of me is to discuss oncofertility in a case-based discussion. These are my disclosures. And this is my outline. After I give a brief introduction on the general principles of fertility preservation, we will get into more detail about oncofertility by discussing 3 different cases. One which is on breast cancer, another on hematologic cancer, it's specifically Hodgkin's lymphoma. The third case is on testicular cancer. So fertility preservation is the process of saving or protecting oocytes, sperm, or reproductive tissues so that one is potentially able to use them in the future. It is an exciting new discipline to keep up with the progress in other fields like cancer therapy. And there is an increasing demand for fertility preservation services worldwide. There are parallel histories with cancer therapy and reproductive medicine. And if you go through them, somewhere between 1970 and the early 2000, there were rapid developments in cancer therapy, causing increase in cancer survival. Around the same time, there were developments in the freezing technologies in assisted reproductive technology. The first IVF baby was also born, and there were advances in ART like genetics, hormonal therapy, and the like. So that when these two came together, they brought up the societies of Fertiprotect, International Society for Fertility Preservation, or the Oncofertility Consortium, because they would really marry the best of both worlds and have the field of fertility preservation. So fertility preservation has many indications as of today because it has expanded beyond cancer. But for tonight, at least, we will just be discussing about fertility preservation before and during cancer therapy. And the reason why cancer therapy is the one that really pushed the progress in fertility preservation is what it did. That is by doubling the survival of cancer, the 10-year survival rate of cancer patients between 1970 to 2010. And with that, there were more patients that needed some improvements in their quality of life. However, when you do improve the survival of your patients, when they focus on specific quality of life issues, they found that really cancer fertility in cancer patients was hugely diminished, average of around 40% decrease. However, in certain cancers, like in breast cancer, the decrease in fertility would be even more than that, something like 70%. So what was happening then was with cancer diagnosis, they would immediately proceed to treatment and you would have increased cancer survivors. But again, the quality of life issues came up, and one of the most noticeable was infertility, because infertility became the single concern among young cancer survivors. There are many strategies now being advocated for adults and children who require fertility preservation. And for tonight, we will be talking about the post-pubertal strategies for both men and women. And this will include both the experimental and the established methods of fertility preservation. But fertility preservation, as you would know, has its own barriers. In fact, the reason why I'm here is probably because many of you have not heard about it too much. Health professionals avoid discussion of this due because they may have the wrong information, they have the sense of urgency to carry out cancer treatment without thinking about the parallel treatments that may be done, and or are completely unaware that it exists. The patients themselves avoid discussion because they might be overwhelmed by the cancer diagnosis and are unaware of the consequences of cancer treatment, and that delaying treatment may negatively affect or impact their survival. Of course, there are other issues like financial barriers. Just to show you one of this table which summarizes the awareness among people involved in fertility preservation among Asia. And they're all saying the same thing, meaning there seems to be a huge disparity in awareness among physicians, including oncologists, the OBGYNs, various clinicians, about fertility preservation. In our own study last year, 58 to 85% had no exposure among these are oncologists about fertility preservation, and 57% never have referred to an REI. And it really means a lot the way we counsel our patients, because in this table, the regret scale among survivors, cancer survivors, the regret scale is much lower if they're counseled by a team coming from the oncologist and the fertility specialist compared to counseling done only by the oncologist. On the other hand, their satisfaction with life scale is much higher, again, if they are counseled by a team between the oncologist and the fertility specialist compared to the oncologist alone. But why? What is the real reason why all this happened? Why is fertility really a problem in post chemotherapy or radiotherapy patients? This is because of the gonadotoxic effect of the different kinds of therapy being offered to cancer patients. The toxicity risk is highest with pelvic radiation, followed by alkylating agents, followed by your platinum chemotherapeutic agents, and down the line. And it also matters when you apply the gonadotoxic therapy. This is as far as the age of the patient, because the younger the patient, the better it can probably withstand the effect of the gonadotoxic therapy. They say that each course of chemotherapy will make the ovarian reserve of the patient decline by about 7 to 10 years, as depicted here, whereby from Octem, suggests it is for about 10 years, and from Divine, it's about 7 years. So every time you give your cancer chemotherapy or radiotherapy, there might be a decline in fertility by at least 10 years. If you treat a 30-year-old patient after the chemotherapy, the ovarian age would already be 37 years old. And these are the gonadotoxic risks of the different classes of your chemotherapeutic drugs. I think you already know these. So the highest, of course, belong to your alkylating agents, followed by your platinum agents. They have even been grouped into various categories so that you could predict the risk of premature ovarian insufficiency. So your alkylating agents would have a high risk of greater than 80% PUI, whereas your platinum agents would have an intermediate risk of about 20 to 80%, and those with a lower risk are your other drugs like your bleomycin and your methotrexate and the others. The males have a similar but not exactly the same response. They're also very susceptible to the effects of gonadotoxic therapy. However, they have different tissues that respond differently to the chemotherapeutic drugs. The Leydig cells in your among your organs, your Leydig cells are most resistant, whereas your spermatogonial stem cells are most sensitive, meaning that depending on what you give, you might be killing your germ cells, your spermatogonial stem cells, but your Leydig cells, which produce your secondary sex characteristics, might be intact. Again, they have similar descriptions as to the severity of the gonadotoxicity of the different groups. The highest coming from the alkylating agents. This is also for the males, and then similar categories in the males. So that in males they will have the same gonadotoxic rate, 80% chance for causing permanent azoospermia in your alkylating agents and down the line. When you talk of radiotherapy in men, again, it would depend on the dose that is applied to the male. They say that the critical level will be approximately 6 gray, where higher levels would cause permanent azoospermia, whereas those where you give lower doses may have transient or no effects on the sperm production. So if you would review things either for men or for women, if you would try to do fertility preservation methods before the start of chemotherapy, and if your patients survive, they will have a chance for a possibility of future parenthood. So that is essentially our message today, to try to encourage our partners to encourage fertility preservation among our young patients. And when we say patients who are probably candidates for fertility preservation, these constitute about 10% of all patients diagnosed every year. they constitute the group, the age group that can possibly avail of fertility preservation strategies. In our calculations, it might amount to somewhere between 10 to 15,000 patients in the Philippines per year. So following all these, we just like to remind you of the ASCO guidelines originally made in 2006, revised in 2013, and again, most recently revised in 2018, and seconded by the American Society for Reproductive Medicine, that healthcare providers should discuss the possibility of infertility as soon as possible before gonadotoxic treatment, and patients who express an interest for fertility preservation be referred immediately to the reproductive specialists. So let's go to our case discussion. First, we have our first case of breast cancer, which is a 30-year-old woman married for 2 years, no living children, and no other medical illnesses. She has a diagnosis of breast cancer, underwent surgical treatment by lumpectomy about 2 weeks ago, and she's scheduled to have adjuvant chemotherapy in another 2 weeks. Chemotherapy would be followed by long-term adjuvant endocrine therapy with tamoxifen for 4 years, and she has been having regular menstrual cycles, and her last menstrual period was 17 days ago prior to the referral. So this couple is requesting fertility preservation. The question is, what are the options of fertility preservation for this couple? Which one is preferred? With limited funds, is there anything that can be offered? What is the importance of early referral of such cases for fertility preservation? We'll be answering all these questions in our subsequent discussion. But before that, this poll question for an interactive effect for this webinar. What information from the oncologist would be of utmost importance in planning the fertility preservation strategy by the fertility specialist? The type of cancer, A. B, the planned treatment, meaning the chemotherapy, the drugs, the courses, the radiotherapy. C, the maximum time before cancer therapy has to be started. And D, all are important. Okay, answers coming in. I think I phrased my questions rather easy. Medyo leading yung mga questions ko. Pero anyway, this is good for our discussion. So I think I can already proceed. So just as a background, in the Philippines, among women, breast cancer is number one, and uh, based on the study by Maltaris way back in 2006, the 5-year survival rate was 86% at that time, meaning a high rate of them will be surviving, and probably breast cancer will be requiring fertility preservation. Will be a good group of patients for fertility preservation. Indeed, in a study in Belgium, for all patients referred for fertility preservation, breast cancer constitutes 50%. So they constitute the biggest bulk of the pie for fertility preservation. And these are the options or the fertility preservation strategies: your ovarian tissue cryopreservation, oocyte cryopreservation, embryo cryopreservation, specific fertility sparing procedures, and some experimental methods, including GnRH agonist suppression. So how do we choose what option to take among women with cancer? Depends on several factors: the patient's age, and age would already constitute ovarian reserve, and you determine this by checking on her anti-Mullerian hormone. Hindi na masyadong ginagamit ngayon yung follicle stimulating hormone, FSH. Also, the type and stage of the malignancy, especially its estrogen sensitivity or hormone sensitivity, the type and dose of the chemotherapeutic agents that are going to be given, and the availability of trained clinicians and the laboratory for fertility preservation. So it's important to have a very well coordinated multidisciplinary team in place for the proper implementation of fertility preservation to avoid delays. But if you want to sum up things, ito talaga yung kailangan yung malaman. The fertility specialist will work within the time limit set by the oncologist, what we call the fertility preservation window. If you give us 2 weeks or more, then we'll probably choose embryo freezing if the patient has a partner, or egg freezing if she's single. And we will be giving letrozole, we'll be adding letrozole during the stimulation if it is a hormone sensitive cancer, to keep the estradiol below 500 picograms per ml. And there are many ways of doing ovarian stimulation protocols for optimum yield. However, if you give us limited time, less than 2 weeks, we'll be forced to make use of ovarian tissue cryopreservation with subsequent transplantation where the patient is already in remission. And then another possibility is to add GnRH agonist co-administration for ovarian protection before and during chemotherapy, either kasabay or the only thing that we'll give in case the patient does not have money for the other strategies that we gave. This is just to show you the study by Lorit, which tries to describe that the, the survival rates in those delaying treatment, cancer treatment, for 1 month or 2 months or 3 months seem to be the same. And it only really changes beyond the third month, the survival rate. So again, I am not sure if this study was well conducted, but it gives us an idea that there might be some room for delaying treatment and yet not affect the survival rate. So just in a nutshell, I know most of the audience are oncologists. When we do either oocyte cryopreservation or embryo cryopreservation, we talk about a minimal time of about 2 weeks. Both will follow essentially the same protocols. We have controlled ovarian stimulation for 2 weeks, oocyte retrieval for 1 hour. For oocyte cryopreservation, we get the eggs and immediately they're stored. Whereas if the patient has a partner, meaning we can get sperm, we put them together and form embryos and freeze them either on day 3 or day 5. So the only difference really between the two is the presence of the sperm, but essentially the time required is the same. It's about 2 weeks as compared to ovarian tissue cryopreservation, which is completed in 1 day, immediately, actually, with a procedure, a laparoscopic procedure that may last only about 1 to 2 hours. We already get what we need. It can be the whole ovary or strips of cortex from the ovary, and then we process them in the lab, form strips, freeze them, and in due time, when the patient has recovered, they will be thawed and we can place them back into the patient's anatomy, whether usually in the ovaries, for for transplantation. And finally, the other choice is GnRH agonist as a possible fertility protective drug. However, this is a bit controversial. And according to the 2018 ASCO guidelines, GnRH analogs are not to be used to replace accepted fertility preservation procedures, meaning you don't choose them because you want them. You only will be giving GnRH analogs as a co-administration, or because you are not able to do the other procedures, you will only be giving them as a for sort of a uh, a last resort. Pero it's not the best. And you give this 2 weeks before the initiation of chemotherapy, up to 2 weeks after the last dose of your chemotherapy. So the answer to our poll question 1 is letter D, which I remember in the poll result a while ago, I think 94% of you got it. So thank you. But I think my question was also a bit leading. Medyo may madadaling mga ano dyan, may testmanship, you will be able to answer it very well. Thank you very much. So hindi naman pala masyadong ano, alam niyo naman pala. Case, again, follow-up case for our follow-up case for the same follow-up question for the same case. What do you need to know before you start controlled ovarian stimulation? Are there any other genetic information that you'd like to know? And how and when would you start controlled ovarian stimulation? What will be the goals? Which protocol to follow? What gonadotropin at what dose? And what would be the choice for ovulation trigger? Well, these are questions that will be answered by the fertility specialist. But for the oncologist, probably it will just be good that you understand the general principles for these. So, poll question number two: what other biomolecular information do you need to plan for the treatment of this patient? A, presence of estrogen receptors in the tumor. B, BRCA status. C, serum anti-Mullerian hormone. Or D, all of the above. This is question number two. What is, okay. So answers are coming in already, but more are still for letter D. I think we can come back later for the correct answer for these. So in fertility preservation and breast cancer, it is important to know the estrogen receptor status of these particular patients because it will influence our choice of drugs. And 80 to 85% of breast cancers is known to be ER positive. And from our point of view, it might be more practical to treat all breast cancer patients as hormone sensitive so that we will not get into trouble with our ovarian stimulation. If another thing that we would like to know will be the BRCA status of these patients. And why do we want to know about this? Because comparing those that are BRCA negative compared to those that are positive, we're able to get less oocytes and less mature ones, and the total embryos that we eventually store for freezing are significantly less. So we would really like to know the BRCA status of all our patients. As for ovarian stimulation, this is again in our realm, but here we would like you to understand this. We normally have a conventional start for our 2-week ovarian stimulation. We start at day 2 or day 3. However, when you refer patients to us, of course, the patient is not necessarily on day 2 or 3. They might be in day 15 or they might be in day 21 of their cycle. And normally, do we have to wait for day 2 to 3 to start our ovarian stimulation, further delaying the plan for chemotherapy? So there are now studies which show that wherever we start in the cycle, if we're just going to induce the formation of eggs, they can actually form the same number of good quality eggs. So the random start ovarian stimulation is now accepted, and comparing it with conventional stimulation, we have comparable yield of oocytes, comparable developmental potential of oocyte to embryos, and reduced time interval. However, the only difference is that we might be using a higher dose of gonadotropins during this particular cycle. And what we use to trigger, we normally use to trigger HCG, but we don't use HCG for our fertility preservation cycles. We use GnRH agonists to reduce the risk of ovarian hyperstimulation syndrome. But another revision that we can do is to trigger with the higher dose depot. And this could actually be the start for ovarian protection in patients who would be having their chemotherapy in about 2 weeks. So there are options that we can do in triggering ovulation. So a last question for this particular case: how would you control the estradiol levels in breast cancer women as her ovarian stimulation starts? What serum levels of estradiol would be the upper limit? And how does letrozole reduce serum estradiol? Sinagot ko na yung tanong. And when, at what dose, and when is letrozole going to be stopped. So just to explain to you how letrozole works in our ovarian stimulation in patients with letrozole and gonadotropins compared to gonadotropins alone, the estrogen level is kept below 500, whereas those with gonadotropins without letrozole will be in their thousands. And the number of oocytes are similar, in fact, sometimes higher in patients with letrozole. So letrozole seems to facilitate the harvesting of similar oocytes. And if you compare it to another type of aromatase inhibitor, actually that the group of drugs are called aromatase inhibitors. Letrozole is the premier aromatase inhibitor that we advocate because the other aromatase inhibitor, which is tamoxifen, will be also contributing the peak estrogen, decreasing the peak estrogen levels. However, the number of mature oocytes are much less with tamoxifen, and the eventual total number of embryos is much less. So superior is the use of letrozole. Also, comparing the performance in terms of pregnancy outcomes, they're very similar comparing the FP group and the infertility group. So seemingly, even if you treat with letrozole, the live births per embryo transfer are the same. How do you give letrozole, which is your aromatase inhibitor? In one protocol, you give it 1 or 2 days before you start your injections for your gonadotropins. And you don't stop giving it until your estrogen levels 1 week later is below 50 picograms. So just making sure that your estrogen levels are not going too high up. So letrozole suppresses peak estradiol levels effectively without adverse effect on your ovarian stimulation outcomes. Pregnancy outcomes are comparable, and safety is confirmed with no effect on the survival rates of breast cancer patients. So the answer to the question would be all of the above, and I think most again got the correct answer. There were those who answered A or B only, but we really also need serum anti-Mullerian hormone as part of our treatment so that we can properly decide the dose of our gonadotropins. So it is all of the above. And this is the last question for our first case on breast cancer. She undergoes ovarian stimulation with antagonist protocol. They produce 3 embryos. They cryopreserve them. 4 years later, after 4 years of tamoxifen, she is cured of the disease and now wishes to do family building using her cryopreserved embryos. The question is, what are their chances of cancer recurrence if she gets pregnant as her disease was positive? So that's essentially our poor question. 20%, 30%, 50%, or no evidence of increased recurrence. Okay, so there are some answers. Let us see. This is actually the realm of our oncologists. This is not our realm. In fact, if anyone of you will question my answer, I leave it to you. But from what I gathered, this study by Lambertini in 2018 showed that there is no difference in disease-free survival and overall survival at 7.2 years after pregnancy, comparing those which had pregnancy after breast cancer compared with those who were non-pregnant, the non-pregnant controls. So essentially, no difference. And in another review by the Canadian Medical Association Journal, there's no study to date that shows that there is an increased risk of breast cancer recurrence in women who get pregnant. So the answer, based on my research, which you can contest, of course, because this is not my realm, is that there is no evidence of increased recurrence. That is for the moment. Again, you can bring up your whatever issues you have during the open forum later on, as I was discussing with Dr. Ignacio a while ago. Okay, so let's go to our next. This is case two. This is a 28-year-old woman with Hodgkin's lymphoma, married for 3 years with unexplained primary infertility, who planned to start chemotherapy. Kanino pala hindi ko inexplain. I forgot to mention. The patient was married and had a husband. So the ideal approach there was embryo cryopreservation, because she was given 2 weeks. She had time to do ovarian stimulation, form the embryos, and then freeze them. So that was the answer to the first case. Okay. Now, in this case, this is a 28-year-old woman with Hodgkin's lymphoma for 3 years. And then, upon diagnosis, they planned to start chemotherapy, the Biacop regimen, within a few days, and thereafter, mediastinal radiotherapy. I'm not sure why they needed mediastinal, but probably there was something there in the mediastinum to require radiotherapy. And now they are referring for fertility preservation. So in this case, what are her options of fertility preservation? What is ideal and what is recommended? So again, in terms of incidence, not too high as compared to breast cancer, but still significant. And at the time of this study, survival rates of 45 to 59% were quoted in this particular study. But in terms of incidence of patients undergoing fertility preservation, hematological malignancies constitute 25% of those patients being referred to us. So given that we have very limited time, they will start chemotherapy within a few days. The only thing that we could do is ovarian tissue cryopreservation. The cancer, so which is indicated because this is for cancer patients at risk of ovarian insufficiency and infertility due to the gonadotoxic treatments, especially requiring immediate chemotherapy. And what you do is, I think we discussed it partly a while ago. After getting the ovarian tissues, we form strips, we keep them frozen for years, and we only reimplant them in various methods, reimplant them near the ovary or in various locations in the human body. So for this particular patient, ovarian tissue cryopreservation is the only choice because we only had a few days given by the oncologist. So how would you counsel this patient about the option of ovarian tissue cryopreservation or OTC? What OTC issues must be discussed during counseling and included in the consent? So essentially the poll question, what is the most important issue against ovarian tissue cryopreservation and transplantation in this case? Failed graft neovascularization, it requires IVF to achieve pregnancy, the risk of cancer seeding, and all are equally important. I'll give you a clue. It's not the same as the first two answers, first two questions. Pero sumagot na yung karamihan. And that was my trap. Let's talk about it later. So let's discuss ovarian tissue cryopreservation. So ovarian tissue cryopreservation was very, very recently accepted as a non-experimental strategy in fertility preservation. This was only last year, late last year, November 2019. It used to be they thought this was experimental, but now with much better graft acceptance rates and also higher pregnancy rates, it has now been considered as a standard accepted form of fertility preservation. What do you need to discuss with patients to be included in the consent? Aside from the risks of laparoscopy and anesthesia, you have to discuss the risk of cryopreserving ovarian tissues with a risk of cancer seeding, especially in hematologic cancers. There is also a risk of failed grafting upon reimplantation Pero maganda na, there's a lot of improvement in the uptake of grafts. There used to be ethical issues, but it is now an accepted standard option. The aim to achieve pregnancy can be that can pregnancy can be achieved spontaneously, and only in those which is not achieved by spontaneous pregnancy do you have to go to IVF. Of course, cost is a major issue. And what about the health of children? There have already been over 130 live births from ovarian tissue cryopreservation and transplantation. So it seems that with the absence of abnormalities among these children, it seems to be a safe procedure. So when you talk of hematologic malignancies, probably the Hodgkin's lymphomas, acute ALL, and probably AML to a certain extent will be the ones requiring fertility preservation because they have the bigger young population affected and a higher cure rate. So with these statistics, then probably they will be the more likely types of hematologic malignancies that will be referred for us for fertility preservation. In fertility preservation in hematologic malignancy, permanent hematuria is achieved in only 20%. So, in fact, fertility preservation is not required for all patients with hematologic malignancy. There are, however, survivors with reduced ovarian sac function, subfertility, and a smaller fertility window after chemotherapy. And these patients are known to have a high recurrence rate, requiring more rounds or more intense chemotherapy, hematologic stem cell transplantation, or even total body irradiation, leading to ovarian failure. So, because of the nature of this disease, this patient requires urgent chemotherapy, and then IVF through embryo or egg cryopreservation is not ideal. However, there is a risk of cancer seeding in the transplant of ovarian tissues. However, Blumenfeld has suggested that when you harvest ovarian tissues after 1 to 2 courses of chemotherapy, who are patients in complete remission, you may already be decreasing the risk of cancer seeding. Coupled with meticulous histopathologic examination before you transplant the tissues, and in some cases, you can even do xenografting in mice to make sure that there is no seeds of cancer in the tissues. Lately, there have been studies on biomolecular markers in breast cancer. Hopefully, in the near future, there will be biomolecular markers to identify the presence of cancer cells in ovaries from hematologic malignancy. So, in case two, if the patient survives the cancer, what what sites of reimplantation of cryopreserved ovarian tissues are possible or preferred? What is the current evidence about OTC as an option for fertility preservation? Is it feasible in all cancer cases? What about the live birth rate after ovarian tissue cryopreservation and transplantation? But first, our review, we've already talked about the sequence of events in these cases, but those that we discussed, we have our orthotopic sites, which are sites near the ovary. And when you transplant them in these sites, you can have spontaneous pregnancy, meaning they will ovulate in the same area, they will be picked up by the fallopian tube, and then after natural intercourse, they can meet in the ampulla of the fallopian tube and result into a natural pregnancy. However, in cases where this does not work, then you can resort to IVF. So both spontaneous and IVF can happen when orthotopic transplantation. However, and the other type, your heterotopic, where you put them in the anterior abdominal wall, even the forearm, the area of your trocar insertion, the rectus sheaths, all of these, they have been tested as heterotopic sites for transplantation. And when they do, this will require IVF. So it's possible to have spontaneous in orthotopic. However, for your heterotopic lesions, as far as I know, there's been only one pregnancy which resulted in a miscarriage. So overall, for your OTC, it has already enabled greater than 130 healthy babies worldwide. Their rate to establish ovarian activity, meaning the uptake, the uptake, the successful graft for to establish ovarian activity is reached at 63.9% following autotransplantation. And there are high rates for spontaneous pregnancy at about 57.5%, meaning only about 40 plus percent will require IVF. So the answer to the poll question number 4 is really only cancer seeding, because in B, you can achieve spontaneous pregnancy, and the issue of neovascularization for the graft is now becoming less and less of a problem with a 65% uptake rate. So it is only the risk of cancer seeding, which is a major problem right now. This is the third case. A 19-year-old man diagnosed with stage 2B seminoma, scheduled to undergo 3 cycles of BEP therapy, referred for semen cryopreservation. So how would you counsel this patient who is opting for a semen cryopreservation? Please elaborate on the chance for survival and the risk of infertility after BEP. So in men with semen with testicular cancer, it has been shown that the probability of having good sperm is only about 59%. The risk that the quality of the sperm is below total motile count, which is the quality of the sperm which is needed for a positive pregnancy after an intrauterine insemination. So quality of sperm is always poorer in testicular carcinoma. And yes, BEP is this is for us, the fertility specialists. BEP is the choice therapy for much of testicular cancer. And if we will follow through the table with BEP, you have a drug which is in the intermediate category, and then 2 drugs which are in the low risk category, but they will be given in multiple courses, and they will be given as a combination. So it's difficult to predict exactly if they will be causing azoospermia, permanent azoospermia, or transient azoospermia. So, and especially in the man, unlike in the woman where you will require some surgery and some anesthesia, in the man you only collect usually by after masturbation. So with the ease in collecting gametes in the man, then sperm cryopreservation is of course advocated. But even with that ease, in studies in the United States, in the United Kingdom, the counseling rate of men who require sperm freezing, only 25 to 38% are counseled to freeze their sperm. So that already talks about how much counseling is not being done to these particular patients. So these are the options for adult male fertility preservation. This is this is experimental, your testicular tissue. So we only have sperm cryopreservation after ejaculation, or when this is not possible, surgical retrieval. You have, of course, your option for hormonal therapy. However, in the latest recommendation by the ASCO in 2018, hormonal therapy in men is not successful in preserving fertility, and it is not recommended. And other requirements or other recommendations from the ASCO: sperm cryopreservation is effective, and that when you try to get sperm from men, please do not get them when the chemotherapy has already started, because there might be genetic damage. Only collect sperm before chemotherapy is started. And if you are going to collect sperm after chemotherapy, do collect only after 3 to 12 months after the last dose of chemotherapy. And in men with diminished counts and quality, it should not be dissuading patients from banking sperm, because we have our ART procedures. So going back, same patients, what are the guidelines in assessing the semen sample submitted is adequate for future fertility? We already talked about this, that there is decreased quality of sperm in men with seminoma. And there are different guidelines according to the different centers. But most of the time you see this. They want to store sperm that is enough to process at least 7 to 10 inseminations. And according to NANGYA, published in Fertility and Sterility, you can calculate this as follows because you normally expect a 50% sperm survival after thawing. And then since you are always aiming for the minimum quality of 50 million motile sperm in one insemination, then this is the amount that you should aim for so that you will have per cycle so that you can have 7 to 10 IUI cycles. For men with difficulty in collecting, there are many methods that we could try to help them in collecting sperm by ejaculation, depending on the problem. This would include penile vibratory stimulation or even electroejaculation. And in cases where surgical retrieval is required for extremely bad sperm deficit, then you can have surgical retrieval through percutaneous epididymal sperm aspiration, microsurgical epididymal sperm aspiration, TESA, TESE, and micro TESE. Okay? And just as a final word, in this study, this 20-year study, only 10.3% of men who cryopreserve their specimen for as a cancer patient were eventually able to use them. And if ever they will be used, so there is a 37% pregnancy by IVF ICSI and only a 12% probability of success after IUI. I think that's my last slide. And since I'm here in front of oncologists, I would like to invite all of you to be a member of the newly established Philippine Society for Fertility Preservation. We are a group of various disciplines. We have OBGYNs, we have fertility specialists, we have gynecologic oncologists, rad oncologists, medical oncologists, surgical oncologists, pediatric oncologists, hematologists. We are here because we believe in the advocacy in trying to help for the fertility of cancer patients. We're having our business meeting on November 18. That is in 3 weeks' time. And we will be inducting new members there. For the pandemic, our membership fee is only 1,000. So these are the details that you need if you want to join our group. And there are many benefits of memberships. Learn with us. Even among the endocrinologists, we're still learning. I'm sure among the oncologists who would like to learn. We will have a lot of resources in our website that we will install store for the benefit of patients, for the benefit of doctors, and also for non-members. I think this is my last slide.